In this webinar, we will learn all about the care of preterm babies after discharge from NICU. Some of the surviving preterm babies may have neurodevelopmental disability in the form of cerebral palsy, cognition problems, visual, hearing and behavior related problems. Intact outcome, that is survival without disability, requires screening these at risk preterms to detect early deviations from normal development and employ timely interventions. We as pediatricians have the responsibility to continue care of babies who are born preterm and discharged after special care in NICU. We will first learn discharge planning, what to include in the discharge summary and a checklist used before discharge, medical care, that is monitoring of growth, nutrition advice and immunization of preterm baby, neurodevelopmental assessment, that is recommendation on screening of these babies for prevention of disability, and give a suggested schedule for multi-domain assessment of these screening tests. Continuity of care from NICU to home requires discharge planning. Each unit should have a place dedicated to follow-up services that includes all or at least most of the services under one roof. Dedicated personnel must coordinate the screening of these at-risk babies. The unit may plan one or more days of the week dedicated to follow-up. The preterm baby family must be given a discharge summary that includes all the risk factors from antenatal period and after birth that may risk development of a preterm baby. Example, antenatal steroids given or not, need for resuscitation at birth, need for oxygen and ventilation. This will ensure continuity of care after discharge from NICU. Having a checklist will ensure patient safety and improve quality of discharge process. A model checklist from our hospital is displayed. The objectives of care that can be clubbed under two headings, one is the medical care and second is the neurodevelopmental assessment. As pediatricians, we are often familiar with medical care of neonates, but there are some special issues specific to preterm babies. Preterm babies take a little longer, about 2 weeks compared to term babies, to regain the birth weight. After that, they must gain about 15 to 20 grams a day. Head circumference must increase by 0.5 to 1 centimeter per week. This is more than in the term babies. The baby's weight, length, head circumference must be plotted on growth charts designed for preterm babies, weekly in the first few weeks of life and then at each follow-up. Fenton's growth chart is a favored preterm growth chart. Tracking of weight and OFC on the growth chart is much more informative than actual numbers. Fenton's growth chart allows plotting till 50 weeks post-menstrual age. One can then change to a WHO growth chart after this period. Preterm babies must be fed breast milk alone till the baby is 6 months age, and complementary feeding may be started after that, like in term born babies. Preterm babies are at higher risk of infections and timely immunization is even more important. There is no change in the schedule of immunization from term born babies. The babies must be vaccinated as per their chronological age. Studies on preterm babies have shown that the protective levels of immune response were demonstrated after standard doses and schedules. BCG and OPV can also be given at or after 34 weeks gestation once the baby is medically stable and ready to go home. Hepatitis B vaccine may be given after 30 days of age or at discharge, that is, if the mother is either protected or negative for the infection. Besides medical care, preterm babies must be screened at the right time by the right methods for neurodevelopmental assessment. The success of a follow-up program depends on the parents' knowledge of need for screening, benefits of timely intervention. They must be educated at regular intervals while the baby is in NICU and later on the need for such testing, schedules of follow-up and anticipated interventions that may follow. Example, laser photocoagulation, hearing aid, etc. ROP screening must be completed as discussed and vision assessment done at 9 to 12 months of age for refraction and squint. Hearing screen and diagnostic testing must be completed before the baby is 6 months old. Developmental assessment must be done periodically, suggest at 4, 8 and 12 months. A neurosonogram should be done at 1 to 2 weeks and repeated at 36 to 40 weeks of life. Baby may be referred to a specialist, neurologist, orthopedician or physical medicine rehab and may need intervention if there is a deviation in development. Often the preterm babies are discharged before the ROP screening is complete. The families must be educated on the need to follow up till ophthalmologist informs that the screening is complete or treatment for ROP is required. In addition to ROP checks, preterm babies must be examined by eye specialists at 9 to 12 months of age for refractory errors and squint and other visual problems. These babies are at high risk of myopia, strabismus, late retinal detachment and other eye problems. Preterm babies are at increased risk of sensory neural hearing loss. The universal screening program that uses OAE in term babies will often miss sensory neural hearing loss. Hence, preterm babies must have an AABR automated BERA screening before discharge from the hospital. An abnormal hearing screen must be followed by diagnostic evaluation and decision to intervene made before the baby is 6 months old. Delay in treatment can adversely affect language development. Neurodevelopmental assessment includes assessment of tone and motor milestones to detect cerebral palsy early. Multi-domain developmental tests must evaluate cognition, vision, hearing and language. Some of these tools are CDC grade, Denver 2, Bailey scale, etc. Periodic checks at 4, 8 and 12 months of age corrected for prematurity are suggested. At each visit, the baby must be initiated on interventions if a deviation is detected from the normal development. Appropriate follow-up is an opportunity to detect early and correct deviations in development. This will minimize disability in preterm survivors. The neonatologist must remain the nodal person to explain to the family the findings of the screening tests and the treatments planned for neurodevelopment. Coordination of the specialist's visits must be facilitated by dedicated staff. They are involved in parent education from start, managing appointments and guiding parents to the intervention programs. The goal of saving preterm babies intact, that is without neurodevelopmental disability, can be achieved by timely screening as discussed and appropriate interventions. In the following slides, you will see the proposed schedule for doing these tests. In each of these tables, you will find the time suggested for doing the test, the appropriate test and what test is being done. Having a checklist of this kind will ensure that we do not miss most important screening and intervention programs.